Anthony, Chris. Come in, guys, over here. You guys figured it out. God, you're so smart. And come in. Lights are all on. Can I get some people up on the deck here? Maybe Lindsay up there. Beautiful. And can you come up here, Cooper? Great. Come on in, Forrest. On the side, Carol. Fabulous. Can you get everybody? How's that look? Yes, I know, but you got everybody? All right. I'm going to stand on the screen. I'm going to stand below the screen because I'm too tall. Come forward in front of me because I'm a little too tall otherwise. Okay. All right. Cheese. Snake Man.
Say pink socks.
Pink socks. Lots of socks, pink socks.
Everybody jump.
Yay, jump. No, sorry. That didn't work out too well for your foot, did it? All right.
Everybody wants a new knee replacement?
Okay, wait. My left side's better. All right. We got it? Thank you, everybody.
Thank you. Good idea.
Borrowed the data idea from Daniel. It's all good. Next year, we'll have a drone taking it. Oh, my God. Okay, as you notice, we've switched the timing a little bit. We planned to start at 1:45 after lunch with our telehealth section. So there are two big segments. One is the sort of the use of data, the use of big data, the concept of big data. We all learn a lot on that topic. And then we're going to go into telehealth in the afternoon because that's another area that's immediately applicable to the world that we live in. Before I do that, I have a couple of announcements. First of all, I'd like to announce our sponsors. As you see here, Johnson & Johnson at the silver sponsor level. We also had, fortunately, both DRG, Medtronic, and Zimmer working with us as bronze sponsors. I'd like to acknowledge Nokia, who is our lunch sponsor today. And actually, that was an amazing lunch. Thank you, Nokia. Presdo, who did the conference app. And this is an app that about half of you have registered with. I'd encourage you to download it. It is a really, really good platform for us to engage in a dialogue to follow. It is linked to LinkedIn, so that the data can flow into LinkedIn from the app. And so you have the pictures and photographs and allows you to manage that. Also would like to point out that we had some minor human error issues, and we didn't get HealthLoop on our list of sponsors, and I appreciate them exhibiting with us. And you've heard a lot about their platform that we've used with great success at UCSF to manage our patients. I remind you to turn off your cell phones. You probably all turn them back on again after the last segment. And I think with that, we'll go into our next talk, which actually I believe I am getting. So if we could talk a little bit about this. So telehealth, and I'm going to put this down for a second. So the question of telehealth. So telehealth in orthopedics is, I think, an idea as time has come. And so my role here is to sort of set the stage of where the opportunities are within telehealth, what we can get out of telehealth, and then following me, we're actually fortunate enough to have Brigham come back up and talk about the companies and areas that he's working with in this space. And afterwards, Jordan Shlain, who's definitely done a lot to move the ball forward in this area, is going to talk to us and talk to you and bring out some of the key elements and talks. So an idea as time has come. Another idea as time has come would be the clicker. Anybody know what happened to it? Is it on the table? Ah, we're behind there, sorry. So the connected patient is something that is a nice term, but it's basically defines the concept that we have these devices on us. What most people don't quite understand is how big this is and how fast it's growing. We're talking about $77 billion in 2015. It's already 20% more than that, and it's going to grow at that rate for the next decade or so. And then if you look at the piece of mobile health, and that's the same technology when applied to a mobile device, you're talking about a cumulative annual growth rate of 34%. That's a doubling time of like 3 years. It is remarkable how rapidly this is growing, not just locally, but globally. So the question is this a move? How do we leverage it, right? Is it a simple, is it a movement, is it a trend? Well, it's definitely a movement. The adoption of digital health tools, if you look at how many people actually go into the EHR and download the data, which several years ago was not possible, you're talking about 20% of patients now will go into the EHR and download some segment of the data. And as has been mentioned before, with that data, they're willing to share it for medical research. And not only that, of course, they want it to be used and for care. Now, the sharing part's key because that gets all around the whole HIPAA issue. If I, as a physician, collect data from a patient, I have to control it, I have to capture it. But if the patient downloads it and wants to share it with anybody they wish to share it with, it actually opens up a whole different opportunity platform. And it's not even a movement, I'd say it's almost reality. We're talking about 46% are active digital health adopters. They have some kind of device on them today, which is just remarkable if you think it's only about 1 in 5 people were toying with this idea last year. And 25% of Americans own a wearable. And everybody says, oh, yes, I know the data on Fitbit that they don't use it for more than 6 months and it winds up in their drawer. But it winds up in their drawer because they traded it for an even more accurate device. And when the devices start being rings on your finger that you don't have to worry about, that are much more accurate because they're linked to your body in a better way, or they're eventually implantable. But right now, today, it's the rings is next. You're talking about an adoption rate that's going to continue to rise, especially if the patient gets, or the person gets feedback which they find useful from it. And the other thing about telehealth is that many of us that are in the clinical trenches don't realize is that the ATA conference, the American Telemedicine Association conference, is pretty much as big as the American Academy of Orthopedic Surgery meeting. There are thousands of people there, thousands of companies looking at addressing the same problems we're addressing. Guess who's not there? The clinician, right? So this is definitely moving forward, and it's not only moving forward in the academic arena, if you will, and the consumer arena, but the policy arena. We'll hear a little more about this later. But all the states are moving forward, are creating definitions for telehealth so that the economic marketplace can rise around it. What's interesting about this definition in California, I'd like to point out, is that the way it's written, while the patient is at the originating site, and the healthcare provider is at a distant site. This is the definition of patient-centric care, because the clinician thinks of themselves as being at the center and the patient being distant. And the way the law is written is that the patient's at the center, the physician is distant, and we're bringing things to the patient. That is the whole concept of telehealth. It's a reversing of the framing. And this from the Center for Connected Health Policy, but none of you knew this center existed, but they actually have published this data point. 200 new laws published last year, specifically looking at the question of telehealth and defining it across the United States and multiple states. So what does the orthopedic patient want? And that was a query that was asked me during the break is, what makes ortho different? It doesn't make ortho different. We want more or less the same things that they want. We just want to customize for our patient and our models. They want healthcare delivered much like the rest of their lives on their phone. They want to arrange appointments on a website. They want to share their data with a doctor seamlessly. This is nothing new. This is interesting. They want to manage the care of their family member remotely. So one of the big growth businesses right now is this issue of managing care for the elderly remotely. Because most of these folks are living to be older, they may break a hip and have other issues, but their family members are distant, and it's very challenging for them to manage the care of their loved one, and where are the tools we need for that. And also, as was said earlier by Nick, I think that this issue that in his breakout, he mentioned that fee-for-service will never go away entirely. I don't think in-person visits will ever go away entirely. It's the unnecessary in-person visit that will go away entirely, especially the one that's unnecessary from the patient's point of view, not necessarily the clinician's point of view. So I showed you this slide earlier, this whole question of telediagnostics. That's part of what orthopedics wants from the world of technology. But we also want telerehabilitation. There's a numerous number of very good platforms that are now taking rehabilitation online and providing excellent results. As Megan mentioned on their platform, we're able to do that. And then there's teleprevention. Now, we tend to think about orthopedics as bones, bone, muscles, but really what impacts and addresses, and so what impacts the outcomes of our work that we do in the clinical setting is often something that's outside our specialty field. We know that weight loss can have significantly positive effects on the progression of disease. Psychiatric issues can have a huge impact on outcomes, et cetera, all the way down. What tools can we have that we can implement and deploy remotely to patients to help constrain those risks so we can do a better job managing their overall care? Telecare path oversight. So a lot of clinicians now are working in multiple hospitals. So maybe we think that we can handle the patient in the hospital. That's great. That's your hospital. What if you're working at 4 hospitals? What if they're 20 minutes apart? What tools can we have available that will allow us to track the patient's course during their disease illness process and allow us to manage them well remotely without necessarily having to travel over the state? I call this tele-sci-fi because it's pretty amazing that now if this patient needs a 3D printed hand in a distant part, we can simply send a software plan and have it printed locally, depending on what the indications are. Teleporter, we can do that today. We can actually do hologram images of ourselves in other places. Why can't I do that today? Because this is actively being used in gaming software. Tele-oversight, this has been mentioned, I won't go over again, but the idea that this patient who is fully digitized is throwing off a lot of data, and all we really want is alerts and process data, so the ability to track our patient and manage them as we go. Tele-revenue is something we hinted on earlier with when Brigham was up, because patients actually are willing to pay for convenience. And it can be monetized. The ability to deliver services in a way that's more convenient for them is something that can be monetized. And that's part of that sort of remainder of the fee-for-service model. It would be something that would be above and beyond what they pay for insurance. Tele-integration. I don't think this has been done yet, but why is it that I can't go to my iPhone and download a series of apps that are customized to Taha's particular issue, and then he just has them on his computer and they all talk to each other integrated? I guess that's Redox fundamental ongoing, but it's not done yet. Why isn't that not happening? We would like to see that happen. And I'm finished with this slide. This whole concept of telehealth and patient-centered care. Now, it is actually the telehealth movement that's going to enable patient-centered care, and it's a whole different discussion about what patient-centered care is. I have a talk that's up on the Exponential Medicine website that I gave this year, which I thought sort of came up with this, or it came up with sort of exposed this idea that maybe, just maybe, the patient-centered care movement is what's going to disrupt the physician-patient relationship to a point where the physician no longer is at the center. And when that actually happens, it opens up the ability for the patient to migrate from platform to platform in a way that will completely reverse and disrupt the way we think about the way we deliver care. It is the Copernican revolution where the sun no longer revolves around the earth revolves around the sun, the other way around. So if you're interested, take a look at that. Another really nice piece on by Ian Gallifant from MetaLink, he just published on LinkedIn, looking at the data that sort of shows where the tipping point might be for this change to patient-centered care. So this is just sort of a framing concept, framing discussion about opportunities we have within orthopedics specifically. It may be broader to all of medicine, but we need this data customized for our workflows so we can implement and integrate it. So with that, I'd like to ask Brigham to come back up and give the second talk. Thank you very much.
And I'm back very sooner than I thought, much sooner than I thought. Thanks, Stefano. So excited to be in this session. This was my original planned session. Talk about telehealth trends and talk about some current examples. Just to level set, a little different than our last sort of discussion up here. One of the things I get to do in my job that I really enjoy is I get to dig in very deeply about the trends that you folks at UCSF are experiencing, what IDNs, ACOs, what programs are being implemented. Most of the time, this is to try and help my manufacturing colleagues figure out what the heck's going on, because they are trying to watch what's happening with you guys. There's consolidation, there's dynamics with payers, there's different types of alliances. And in doing that, really over the last 3 years, I've done a lot of different work and a lot of research on sort of the different aspects of this. And they end up getting to be very geographic centric, which if you ever want to really understand this country, try and compare healthcare in Seattle to healthcare in Baltimore. It's really interesting. You start to understand the characters of regions, why some things have emerged, and it reminds me all the time how local healthcare is. So with that backdrop, I'm going to talk a little bit about, just quickly, some current trends that I'm seeing. And specifically, I'm going to talk about a number of programs that, and this research is pretty recent, that have been implemented both by payers and by systems that include telehealth. I'm listing a few here. You can read some of the bullets. I'm going to highlight a few things. But let me give you some overarching view. I think, first and foremost, telehealth at the moment is really about additional service or perks to some extent. And what I mean by that is that they're trying to offer ways to retain patients. In other words, we have a telehealth offering which makes us more attractive to seek care from. I'm making a broad statement there. That's not always true. But if I look at the whole country, that seems to be where it's getting traction. Either that's something you pay for because you view it as a perk, or it's something these systems, which might compete with each other, and here we're looking at Seattle systems, are using to compete for patient flow. And depending on, again, those local dynamics, Seattle's a great one because there's a bunch of big, well-organized, consolidated systems there. They want to compete for those high-value patients. Nowhere is this more true, I'll point out, than orthopedics. So I'd say that's comment number one. Comment number two is that on the back end, somebody mentioned macro earlier, the game is readmissions, readmissions, readmissions. And if you have a way to manage patients better, to reduce admissions, or perhaps, in the macro sense of the word, move people to a different setting of care, I guess is a polite way to put it, telehealth is a real angle to do that. And I think other folks are using this as a way to improve those readmission scores, whether it's in orthopedic surgery or in general, and they're also, again, somewhat transitioning patients to outpatient care. And let me say that I think that's done with the best intentions, so I'm not being cynical about it, but I will say that realistically, you don't want expensive patients with bad insurance in occupying beds in your inpatient facility. If you're a CFO, that's not what you want. So telehealth can represent a way to treat those patients, follow up with those patients in a setting that is less expensive. So that is another real trend. This is an example from California, and this is the payer end of the world. So what's interesting is that telehealth programs are coming from all in any directions. So we just showed provider. These are some payer-sponsored groups related to some of the ACOs there. I'll comment in a minute on some employer ones. And I think my overarching comment here is just simply that telehealth is being tried by many different groups. What this creates, though, is sort of an odd situation. We're talking about the Anthem sort of telehealth or live health online initiatives. How does that overlap with what Providence or St. Joe's might be doing? Do I now, as a patient, have multiple telehealth apps? And I'm just not clear that that's been totally aligned. To be fair, most of this stuff is in pilot. I mean, I'm sure our colleagues at UCSF could talk about their successes and things that have worked well, things they've done with payers or with employers. But in short, as we sit here right now, it's a little bit confounding on who's actually going to drive. It strikes me that the payers like this because they can track stuff. And in general, that is a position they like to be in as actuaries. The physician side, I think, is a little bit more demand-side driven and also, truthfully, can lead to better care. So I think the physicians are also motivated. My question is, who has the right infrastructure? So if we think about our Silicon Valley friends, like who is actually building and paying for these applications is going to be an important question and have different implications depending on the answer to that question. I wanted to highlight this one just because we're an orthopedics conference. So partnership between Hoag and St. Joe's, and I think this has actually evolved to even more of a sale, but I'll keep out of the M&A detail. In short, you had Specialty Orthopedics Institute that partnered in a telehealth setting and broader setting to partner with St. Joseph's to improve really surgical follow-up. That was one of the initiatives. And we're able to do that. And I sort of saw this as Hoag going, okay, where are my patients going after they're having surgery with me? Okay, great. Can we team up and link and figure out how to coordinate that a little bit better? I think this is great, right? I think you'll see more of this. I think if I'm a private or semi-private or semi-specialized orthopedics institute, you know, I'm on a little bit of an electronic island, right? If I'm not partnered or coordinated with, at the very least, the dominant outpatient player in my region and probably inpatient as well. So I think we'll see more of these. I think the value on surgical follow-up can be clear. I think there's a lot of low-hanging fruit. And I think if I'm Hoag, I'm doing this because I want to tell my patients who are choosing potentially between me and the orthopedic shop down the block that I have this care coordination that I can follow up. And if I'm a specialty shop, that may be hard to do. And you can see some of the stats on the bottom for this wellness corners, definitely success. And I may have led actually the expanded partnership there. And then just sort of lastly, I'll just mention employers, and I think this is again Seattle focused, but in every case here, you have major employers in the region sort of offering telehealth options, among other things, to their employees. And what's interesting, sort of, I talked a little bit about employers, other people have spoken about them, and even there's a startup focused on it. Look, they have the potential, the leverage, and the sort of impetus to really push programs like this, right? I mean, they're footing the bill, and they're their people, so they should want to do this when it works. Truthfully, I think so far, it's sort of a perk. It's kind of like if you were interviewing at Amazon, they might feature that in addition to your pay and your bonus, in your benefits package, you have access to this private telehealth network that gets you some better access or better follow-up. So it's almost being viewed as in the revenue category, Stefano, as you described it. This is a way to do that. And I think when you see that type of activity, if you're thinking about it from a provider side, again, I think you have to think about telehealth as a revenue side opportunity, not just a cost side opportunity. I think that's definitely true. And I think that was what I wanted to say. I mean, I'm pointing out here simply that there are very specific management programs, and I think in general we're seeing these emerge to be more effective. What I've seen is that you need a staffed care management team behind your telehealth application, and you need a telehealth application designed for the patient journey of your patients. That not only means what they are clinically likely to develop, but the care they're likely to experience in their community. So the more tailored or the more local, if you will, I think the better, the more successful, in my opinion. But again, I think, do you need one master telehealth program or specifics? I think we'll go through some fits and starts on that over time. That was what I wanted to say. Thanks.
You can stay up. Yeah. Jordan Shlain is the president, founder, but not CEO anymore, of HealthLoop, and runs a clinical practice, so a very active clinician and very involved with telehealth and digital technology. And I'm going to give you another mic. One second.
Medical school. I found that the orthopedists were generally the funniest guys in the room, so I thought I'd start off with a couple of jokes.
Oh, good.
Is that okay?
Go for it.
So a guy goes to his doctor and says, "Hey, doc, is it true if I quit drinking and I quit smoking, I'll live longer?" And the doctor looks at him and goes, "It'll sure seem like it." So the other joke is, what do you call a person who drinks too much, smokes too much, and doesn't listen to what the healthcare system asks them to do? A voter. So anyway, just to kind of lighten it up a little bit. So I think what we just heard, which was really enlightening, speaks to the fact that the ecosystem that we generally think about in healthcare, and I mean that clicker too at some point, is whoops, that's the last slide, but it could be the first slide. It's not an ecosystem, meaning if you do this, what will happen over there? It's actually, it's more like a freakosystem. Like if you do this here, you have no idea what the consequences of it will be over there, and then everybody else is doing it over there too. So I think it's important to realize that this is not like the banking system or retail, where if you do something here, you know what happens there. A does not necessarily go to B to C. So we're in this moment in time where there's just a lot of bits and pieces going on. The other thing is what I've learned at HealthLoop, which I started in 2009 in my office as an experiment, was nothing goes viral in healthcare like it does in the consumer internet world. It goes bacterial, and if you're lucky, fungal. It just goes slow. And it takes a long time to get adoption because everybody wants to do a pilot and everybody doesn't believe that the results over there will yield the results over here, because if you've seen one doctor's office, you've seen one doctor's office. So anyway, so I thought I would briefly talk about, I got in a fight with Sylvia Burwell up at the HHS recently about this. We use language kind of loosey-goosey, and if we don't actually all on the same page about what we're talking about, we're going to get different understandings of what we're talking about and not really have a conversation. So I argued that there are no patients, there are no consumers in healthcare. And she said, what are you talking about? We're going to consumerize and empower the consumer. So it led me on an exploration. This is what a consumer looks like to me. They're in a store. They're shopping. This is what a person who's not a consumer looks like. They're just living their life. And this is what a patient looks like. I've never seen a consumer in the ICU. That was my line. And I just haven't. So I just want to take a minute to be really clear on how we should be thinking about this. Consumers have free will. Because they can decide to do something or not. They've got a lot of choices. They're excited about spending their money. They get to add to their baseline. They buy a bottle of wine or a trip. You had it before you didn't. You find them in a mall and you save money. Patients have tethered will. They must make a choice. So if you have hip pain, you have to make a choice of either doing nothing, which is going to be pain. You can have an injection. You can have physical therapy. You can have surgery. But your options are limited. You've got 4 options, and I maybe a little bit more than 4, but not the amount of choices you have when you're going to buy olive oil, for example, from Italy, which are many. And the other thing is you're oriented around anxiety, which is existential, right? You're afraid. You're scared. You're not excited. And when you get that hip surgery or the injection, what you're getting is something that you had that you lost. Now you're getting it back. Whereas consumers get something they didn't have before. They spent money that they had it. And you find them, this is where you find them. So I just thought it's interesting to orient around like these two types of people, and you can't call patients consumers. It's not really great. It dishonors them. So this is like a 20-minute talk in 10 minutes, so I'm going to go really fast.
10 minutes, you have to ask us questions too.
Okay, so what's going on in digital health? We just heard there's a lot of things, but this is all this stuff in PubMed. These are all the publications in PubMed from eHealth, mobile health, and eHealth. And when you look at the dimensions of the functionality of applications, solutions, whatever you want to call them, telehealth, these are the dimensions. You can inform the patient with it, you can instruct them, you can display information, you can guide them, you can remind and alert them, or you can communicate with them, or some combination of all of them. But these are the dimensions. And so when you look at what people are building in healthcare, so it's almost as though people with mental health problems don't have endocrine problems or nervous system problems. So people are building for very discrete systems. But that doesn't, then you realize that people have more complex systems. And so basically point solution land, what this is. And so what are people building for in digital health? And what's interesting is fitness is obviously, it's not really healthcare. It's more of, that's where the consumers live. But that's where the money is, so that's what people are building for. And they're not really building for anything else because it's regulated and everybody wants to do pilot. So what are they building? Who are they building it for? And this is the fun part, is that little 2% slice over here, that's us. So no one's building for us because it's brain damage to get us to do anything, because we have, as you were saying, this like, where's the randomized double-blind clinical trial? We don't have the money. Those little companies don't have the money to last that long. So this is the interesting slide, and I'm sorry for that little text in there, but this is what apps do today. The majority of them inform, then they instruct, then they record, then they display, then they guide, and almost none of them communicate, and this is telehealth. Well, I would argue that if I asked everybody to take out their iPhones and give me the 10 most common apps they use, they all communicate. Email, text, Snapchat, Twitter, Facebook. So humans are wired to communicate, but somehow we don't want them to communicate in healthcare. We don't even know how to make it to do that. And so what I want to talk about is this is a Blue Cross Blue Shield study about, this is a model of engagement. How do you engage people? And so what you need is a sense of connectedness and continuity. And when you have that, which speaks a little bit to trust, that will empower patients to feel informed, have literacy, feel comfortable asking questions, and have a dialogue. You can only have serial monologues with Google. And it gives the doctor time to explain. And once you have that, then there's engagement. So I actually think that we should kind of coin the sixth vital sign, which is engagement. Because the truth is that blood pressure, heart rate, and respiratory rate, and all these other vital signs, they don't tell you anything other than that you're alive or you're dead. And they may provide some interesting insight. So, and then there's vitality signs, which I'll skip over lately. And the HealthLoop story really is in my office. Lady came in with pneumonia, cough, fever, shortness of breath, and I sent her home with a prescription for antibiotics and with my cell phone number. I said, if you're not better, probability that you recover fine is 98%, but if the other 2% could be really bad. 6 days later, the phone rang. It wasn't her, it was the ER. She went into the ICU, put on a ventilator in respiratory distress, and almost died. And I thought, why didn't she call me? I gave her my phone number, and I made it that easy, and I always answer my phone. And then I realized, well, maybe she was sick and she just didn't feel worse, so she just kind of played it out one more day, and wound up in the ditch. And I realized that when you're at home, if you're a patient at home and you're sick and you're anxious, you're not a consumer, you're a patient at home and you're sick, you're asking yourself, am I worse today, am I the same today, or am I better? And if you're better, you're not going to call me. And if you're the same, you're not going to call me. But if you're worse, you might call me. You might call me. But if you're the same over many days when you're supposed to be getting better, same is a negative trend over time. And that was my insight, which led me to start this thing called Same, Better, Worse, which eventually turned into HealthLoop. But it was really an experiment in my office of how do you follow up with patients after they've left? Because really, when you get the diagnosis, you're the main actor in your healthcare movie. Act one, scene one. Here's your diagnosis. Here's your treatment plan. You have no idea who the director, the producer, and the supporting cast is. You don't know what lines need to happen, when different props need to come and go. So, how do you want your movie to end? Inside and outside of the hospital. And it led me on this kind of what do patients want, and they want to live their lives with minimal impact of illness. They want to have trust in their medical teams. They want convenient communication channels, and they want a sense of control. And what do doctors want? Well, we want to practice without hassle. We want actionable information, incentives that make sense. We want to be acknowledged for the good work we do, like everybody does. And we don't want to be a data input jockey. I don't want to be entering in prescriptions to the pharmacy on my EMR because that takes me 40 seconds. My handwriting prescription took me 10 seconds. So now I'm doing the data input of a pharmacist. Not a good use of my time. What patients don't want is to have the internet as the first responder, because then Dr. Google becomes an oncologist. Every time you ask Dr. Google, what is this? I hope it's not cancer. Oh, shoot, it could be cancer. It creates increased anxiety, and you can't have a dialogue with Google. You can only have monologues. And they don't want bad outcomes, and they don't want to be alone and disconnected. So the way I think about it is, where's this clinical operating system that helps doctors, helps patients, helps staff, helps everybody to create a narrative, a real genuine narrative about people throughout this healthcare journey? So you've heard a little about HealthLoop, so I won't go deep into it, but it kind of gives doctors a superpower, but it gives patients a superpower. And this was a study that we did at MD Anderson, which I just think is really fascinating about literacy of all things. Like, we're smart, we're all doctors and business people, but when patients are sick and anxious, they may not have the literacy that they need. And what this shows is before you get your ionizing radiation for your cancer, you had a 21% understanding of what you were going into when they gave you the handouts. And after we did a couple videos of these two doctors walking through their MRI machines, and their CAT scans, literacy went up to 66%, 64%. They tripled. So literacy, we can't forget that people, when they're sick, we need to help them understand things. So I think about medicine as the atomic unit, and again, I'm a doctor, so maybe this is doctor-centric, is the atomic unit of healthcare. The thing where all the money flies away from is the doctor and the patient. And the data and the information, I say doctor, clinician, doctor, and patient family, and how that information flows around them and gets to them at the right time will lead to blood tests, radiology, hospital ER visits, all these things that cost a lot of money. So if we try to think about solving some third-order problem up there, and we forget about doctors and patients, and we try to do some process innovation, and we don't bake these people into it, we're going to wind up baking these people into it in the form of an expense. So I've come up with the concept of the trustome. And the trustome is something where these are the elements to create trust with people in applications that whenever you look at a solution or an application, telehealth, whatever, ask yourself, does it do these things? And of these things, which does it do? So does it listen to the preferences of the people? Is it relevant and personal to me? Is it proactive and anticipatory? Is it smart? Is it actionable? Does it create progress? Is it invisible, meaning it's so easy to use, it's low resistance? Is there context, meaning I understand where this information falls with space and time? Again, literacy, which I just discussed. Is it responsive? Is it shareable? We talked about sharing information. And is it safe and private? So these are the elements, and then trust, of course, is the summary of all these things. So I look at through the lens of every product, solution, service, which one of these has and does it have all of them. So in closing, I'll just say, which was the last slide, which now the first slide and the last slide is, healthcare is a people business in need of technology, and it's not a technology business that's just looking for people to fill it in. So I think of telehealth, and there's a lot of solutions, as you mentioned earlier. I think the synchronous stuff, like two people on the telephone at the same time or two people on the video chat at the same time, is interesting but incredibly insufficient because it doesn't meet you where you are when you want to be there. It's still a scheduling phenomenon. So thank you. Am I here? Am I sitting here?
No, actually, you were supposed to do Q&A.
Oh, okay, great.
But I think but you used that time to do the talk. I thought the talk was very good. I didn't want to stop it, but let me just let's just go straight to Q&A. If there's any questions in the audience, and then afterwards I'll introduce the breakout panels. We had all the answers all at the same time, so that's very impressive. I wasn't prepared to ask questions myself, so I was listening.
Sure.
Do you have any questions you want to ask us?
Well, I
from
think,
what you heard?
Well, I think that as an orthopedist who's in the world practicing, I presume you see a lot of things. I mean, I know, TAD and UCSF's a brand name institution. People want to do things there at UCSF. Let me microphone real quick.
Yeah.
Is what is the thing that you see? I mean, are you concerned that what you're seeing won't work? Are you concerned that what you're seeing? I mean, how do you look at something and then decide to get to yes? I want to do this.
You mean implementation?
Well, just even like, what's the funnel process of here are the solutions, here are the vendors, and here's the guy that writes the check. At the end, like.
Yeah, I'll tell you exactly where I saw where I see the bottleneck, and the bottleneck is actually one of the slides I put on there. And if somebody else doesn't do it, maybe I'll do yet another startup. So I learned my lesson the first time, said never do it again. But maybe is the following: if we bring in one other app into our clinic, Julie, where's Julie? She's my physician's assistant. She has to open Epic to look at a bunch of emails. She has her phone line to answer. She has her own personal email she has to answer. She has HealthLoop she has to answer. If I throw, that's 4. So that's not sustainable. If on top of that have an obesity app, a depression app, any other app. So as you know, I've been asking you specifically as a company to merge with other solutions, work with Redox, and this is how I learn about so many of you guys. Is we want a single portal for the data input. Because if that doesn't happen, it becomes a real practical workflow issue for us. That's how I see it. I don't know if, Tad, do you have any different thoughts on that?
I was going to say a variation on the theme, whether it's telehealth or a HealthLoop concept. How many things can you hang on this tree before it becomes less useful as a tool to communicate? So Stefano has just told you we want to put these things together, but at some point, that ceases to be useful too, and it becomes just like the EMR.
Right. I mean, I guess my answer to that, and you may have an answer too, I don't want to cut you off, is that, I was at a meeting the other day with a trauma surgeon, a interventional cardiologist, interventional radiologist, a pathologist, a ER doc, an intensivist, pediatric intensivist, and an oncologist, and an internist. And we decided, hey, let's go around the room and talk about what happens when we wake up in the morning and we go to work, and all the things that we have to do, and then when we go home. And we went around the room and we realized that the difference between like an orthopedic surgeon, a trauma surgeon, a cardiologist, an oncologist, they're all doctors, but it's as different as a pilot, a baker, and a ditch digger. Like the way you go through our lives. So the problem is that technologists see doctor, and they just think, okay, they all have the same needs and use cases, and their day must look the same. There's a doctor's office, there's a hospital, but they don't realize that the needs that we have and the data needs that we have and the communication needs that we have are all incredibly different at different times of our day. And so the way I think about this is, I hope that Epic and Cerner, like, they're big databases and kind of cash registers. Their function is to store stuff and then bill for it. And the goal is like that's going to become middleware, I hope. And then the orthopedist can say, I want this and this and this, and I want to build my own experience. And here are the different applications that solve the different pieces of my puzzle. So you'll log on to, what was your assistant's name?
Julie.
Yeah, so Julie will log on to her thing, and she'll build what she wants to see when she wants to see it in her own way that maps to, UCSF Orthopedics. And that may be that all orthos operate the same way, but I'm guessing they don't, because no set of all kind of homogeneous doctors, even though they're the same specialty, operate in the same way. So I think about workflow as how you move through the world, but then I think about data flow. How does the data flow through your world as you move through it, and how does the data flow influence your workflow? So I'm hopeful that we'll build, Legos instead of, so people can build their own experience.
Yeah, I have one. So I'll answer your question a little bit differently. By the way, I love the sort of context of your two comments, both physicians, right? I heard both, we don't want any more apps, and I also heard, I want my own app, right? Which the app developers in the room will have heard that story before. It gives the technologists an interesting challenge, which they deserve. So with that in mind, what I see actually happening to date, which by the way, I wouldn't say is indicative of what will necessarily, because there is some cool middleware coming together that's going to enable a lot of this to be much more democratized. But at the moment, it's a little bit of carrot or stick. If you look at that Hogue example, right, what worked was we want to retain patients, we need a telehealth program, and our readmit stats are affected by our DVTs and our cardiovascular events, and I've got to have a telehealth follow-up system that's going to track that. And so I improve my stats, we get paid more, and I retain more patients. And I think those are the programs that are happening. It's like when there are dollars on the line, that's what's dictating which of the more individualized apps get put in place. And highlight to that it's highly system specific. The setting of care thing I think is huge. It also matters your insurers and things like that. But to date, those are the ones that are being put in place, and that's dictating what's being done. If you decide that it's cardiovascular readmits, we're going to do telehealth cardiovascular readmit.
Great. All right, guys. Thank you very much. Appreciate it.
Cheers.
And one of the great things about being up here is I get to say the last word. So Brigham, we didn't say we want our own app. We want our customized collection of apps that look like our own app to our patients. So there you go. So we're now going to go into the breakouts, and I'm going to do the same thing we did last time. If I could have, actually, I sent a slide back there. Did it get loaded? Not yet. I'm sorry. Let me see if I can do from memory. I have sometimes faulty memory. But the slide was of our staff that has put this conference together. I really wanted to give them a really heartfelt thanks. It's been a year's worth of work, and it all comes together in 24 hours. And so we had Erin, who's not here today. She actually got pregnant and had their 5th child, but she still managed to find time to help us out. Sarah Woodbury-Trauner, who has been running this conference like clockwork, and I keep messing up her schedule. I know she's in the room. And then we have the team from Michelle, who's been organizing the Structural Congress, et cetera. So we have a really, Nick, who's my executive assistant, administrative assistant at the university, who's been connecting me with all these amazing speakers and making sure we get here on time at the same time. Anyway, it goes on, and was KJ. She's been also extremely helpful. She built our website. So all these people have really put heart and soul into this conference, and I want to just give them a huge round of applause. Christina Portillo, who's been amazing on our website stuff. All right, so if I could have you guys get up. I mean, I've heard a lot about HealthLoop already, but Todd, what are you going to talk about in your breakout?
Learned some high-quality lessons along the way, and going to share what those were.
Fantastic. And Nico?
We're going to talk through a case study example of code to the patient-reported outcomes, looking at a specific orthopedics group, ORA, Orthopedics, and the outcomes that they got by integrating the software into their workflows.
Megan? Fantastic. And Jamie?
We're going to talk about unified telemedicine, bringing all your providers together on a single platform, integrating async and sync all in one place.
Wonderful. Okay, so we'll go to the breakout rooms. You're now familiar with the process, and then we'll come back at 3:25.